First, I will gather more information. I will clarify the intended site of procedure by reviewing the patient notes and results available to me. For example, any previous pathology results. It would be important to differentiate whether this is wrong site surgery or whether the consent form is wrong. Both are serious mistakes, but the former involves patient harm. I will review the operation note and confirm the procedure and operative site. If this is a case of wrong site surgery, then patient safety has been breached and harm has come to the patient. Furthermore, the doctor-patient relationship may have been compromised. I will escalate the situation to the consultant in charge of the list. It would also be important to tell the theatre team in due course. I will liaise with the pathology lab to inform them that they may receive an incorrectly labelled specimen, which could have clinical consequences. The patient should be informed at the earliest possible moment. I will offer to go with the consultant to explain what has happened. I will ensure that they are able to understand and retain the information I am telling them. For example, I will not tell them when they are still in recovery, coming around from the general anaesthetic. This procedure was performed for suspected melanoma, so the patient should be urgently reallocated to another list for timely excision. The patient may wish to have this performed under another consultant. The patient may also need rediscussed at the skin cancer multidisciplinary team meeting. A DATEX or other adverse reporting form should be completed. Wrong site surgery is a never event, and failings at multiple levels have occurred if this wrong lesion has been removed. When the acute situation has passed, I can speak to the FY2 privately to clarify if they've performed the operation independently or if they're being supervised. I will do this in a non-confrontational manner in a private area where we are not likely to be disrupted. I will also leave my pager with another colleague to minimise interruptions. When the acute situation has passed, I could speak to the consultant in charge to seek permission to use this case as a teaching case. This in turn may help to prevent this scenario from arising again in the future. I could also conduct an audit to explore current safety measures in place to prevent wrong site surgery and identify areas for patient care and improvement. The patient may also need to be rediscussed at the skin cancer multidisciplinary team meeting. Most importantly, I will support the patient. They are likely to be upset, even more so in the context of suspected malignancy. It is important to be honest and offer them an apology. I will inform the patient of the local complaints process should they wish to make a formal complaint. And finally, I'll offer to speak to them again when their relatives are present so that I can answer any questions they may have.